Hello, it's Grant and John from the Gray Zone Longevity. Today we're going to talk a little bit about what goes into taking a look at all the factors that relate to aging, all the factors that relate to death and disability, and how these things are monitored and assessed in practice. And the approach is really to take a look at what might kill you or disable you. And all those things actually tie into how long you're going to be healthy and how long you're going to be functional, and whether you can end up prolonging some of this so that you end up getting additional years of life. And a lot of the things we'll start out with things that are going to potentially kill or disable and what you can do to mitigate those and how it's even assessed, because that is one of the challenges is that traditional medical practice right now uses proxies for whether you have disease or not. And those things are not very good. And probably the first domain that I talk about is going to be a combination of vascular disease and metabolic disease, which is a huge topic as far as how we take a look at this. But it is something where if those things are optimized, everything else does better. For example, if your vascular disease is good, as far as you don't have any, or you're mitigating it, your likelihood of getting dementia, your likelihood of getting cancer, all these things end up decreasing also. And obviously all of us are going to end up dying of something. So it's a matter of pushing some of that down the road and potentially changing the things that you end up dying of. Right now, despite a general decrease in vascular disease deaths, it is still a very high likelihood for each of us as far as heart attack or stroke. And the interesting thing is that with those two diagnoses and also with metabolic disease, those things we have incredible power over, and we can objectively take a look at those and change and basically wipe those off the list. I can tell my patients, look, in the next decade, there's no situation which I would see that you're going to have a stroke or a heart attack or suffer consequences of metabolic disease. And those are things we can actively manage. Things like malignancy are a little more complicated. Neurocognitive decline's a little more complicated, but all these things tie in together. So as much as I'll separate them out into certain domains, and the way that we work them up is an issue of understanding that there's incredible interaction between all of these different things that isolate into a silo, but then go, this is something which all these things are interrelated. And then I think one of the big things is that a lot of times people want clever things, and the less clever things, such as diet, exercise, stress, sleep, all those things are huge interactors with this and need to be calculated into this, because individuals oftentimes go, well, I'll take a medication, I'll take a supplement, I'll do this, I'll do that. And if you're not taking care of those other items, you're going to have markedly worse outcomes. So a lot of this goes back to things like what my father talked about in our initial episode, as far as what happens with lifestyle when you take a look and say, well, lifestyle can get you a decade more of quality life. Very few of the interventions I have are going to end up beating that. They can probably add to it, but it is something where we really have to take a look in detail as far as what we do and why we do it, and how all of these things work in a package together, as much as we'll isolate them. So I'll go ahead and start with vascular and cardiometabolic disease. This is something where I think the first thing is to assess where you're at today. So if you come to me as a patient, a lot of times in the beginning, we're going to be doing data collection as far as, where do you stand today? Because if you have some critical disease today, that needs to be dealt with, or even what our targets are if you already have disease end up changing. So
Can I ask a question on that note? Because I really like how you set this up about how these are really the fundamentals of preventing death and disability. Yet in longevity circles, a lot of people tend to just kind of skip over it and say like, yeah, I know all that stuff's important, but where's the rapamycin, right? And I'm wondering when you get a new patient who's unfamiliar with your practice, you haven't had a chance to have this conversation yet. Are they surprised that this is where you go first? Are they thinking, are they sometimes coming in expecting more exotic remedies to be the first thing that you talk about? Or is this aligned with their expectations?
No, this oftentimes does surprise them, because from their perspective, this is something where this is what their primary care doctor does. And they've come to me and they're paying this money. And I go back to the beginning of what their primary care doctor is supposed to do, but they're not actually doing it in the same way. And they'll realize as they go through the practice that, wait a second, the things that I've been told are good and under control are not, and something where it needs to be addressed. And I think that it really is something where people being given false reassurances by the current practice of medicine is a real problem. And, I have a gentleman that I just met with last week who, his ApoB is in the 60s. He's got a lipoprotein A that's negative. He was told, you're great on all that. He's got a thoracic aortic aneurysm. He's got blockages greater than 70% through his LAD.
Wow.
Really, just something where things that he thought that he was good on because of prediction scores ended up not being true. And I had a lady today who came back with her CT coronary angiogram, completely cleared disease, but yet lipoprotein A strongly positive and ApoB of 120, 130. And this is so she would be predicted to need lipid treatment, and the other guy would not be, and yet the disease is totally different between the two of them. And there's obviously lots of mitigating things, whether it be lifestyle or other genetic things that are factoring in. But actually getting an understanding of where somebody is today is really important, and doing it objectively. When your primary care doctor says, hey, everything's great on your lipids and your vascular stuff's great, on what basis did they tell you that? Where's the level of evidence? It's like, okay, they're following the guidelines, but the guidelines are what lead to these patients coming and seeing me as an ER physician with significant disease, where I'm treating them for a heart attack, I'm treating them for a stroke, but yet somebody told them everything is under control. Clearly they were wrong.
Yeah.
Proof's in the pudding. It's like, they're having the heart attack in front of you. Clearly something was not appropriately assessed, but they were assessed by the guidelines. And I had a patient this last week tell me, well, in regard to my lipids, I would like to have you go through, a 10-year prediction rule and 30-year prediction rule as to how aggressive we should be. And I kind of said, well, that's not why you're seeing me, because why use technology that's 30 years old when you can just go and see what your situation is? I mean,
Yeah.
coronary artery disease occurs slowly until you have plaque rupture, but as far as it is something where it builds up slowly, and it's not like it's only just pops up, over 3 months. It's something which is there, and you have disease, and the amount of disease, length of the disease, how much of it is non-calcified and likely to have plaque rupture. That's all sitting out there as risk as to whether you actually have plaque rupture. There's lots of factors that fall into that, and it depends where the disease is, how high risk it is. If you have disease in a small blood vessel and you block that off, yeah, maybe you kill a tiny part of your heart, but you're not going to have a cardiac arrest. You have disease in your left main or left anterior descending, and you block that off, you're probably going to have a cardiac arrest, and you're probably going to die from it. People watching things on TV have a very false sense of what happens with this. When you have a heart attack that causes cardiac arrest, you've got somewhere 7 to 9% chance of leaving the hospital in some fashion neurologically intact. I would say it's even lower than that
Wow.
as far as truly not having some neurologic loss. So I think that so many families, when they come in and their family members had one of these events, think that, hey, my dad's going to be okay, right? And it's like, no, they're not going to be okay. This is a big deal. And what you see of CPR and getting people back and stuff is completely incorrect and completely separate from what the data is. So avoiding one of these events is very important. So yes.
I think too, you bring up an excellent point about catching disease that should be caught that's missed with guideline based screening. And I think the other part that strikes me, I think this ties in perfectly with the whole concept and title of our podcast, right? The gray zone. That I think a lot of people don't realize that when they go see their primary care physician, they're not assessing the gray zone. They're not assessing whether your metabolic and other domains of health are starting to drift out of optimal. They're assessing whether you have disease or an immediate risk of developing disease in the near future, which is very different than the goals many of us have, right? And I think sometimes people don't even realize that that mismatch exists.
No, it is something where people are talking past each other. And I think a lot of times the doctors are not even understanding that they're telling somebody that things are okay when they have no scientific basis to say so. Um, this is something where I have this conversation with new patients in the practice, and a lot of them, yeah, when they come in, they're kind of going, okay, let's talk some peptides, let's talk some rapamycin. And my approach is, let's data collect and see where you're at today. Let's make sure that we've got all the things that could kill or disable you sorted out, and at the point that we have all those sorted out, which oftentimes takes the better part of a year for a lot of these patients, and get that sorted out so that you really are in good shape and you really understand where you stand, that after that, or for some patients concurrent with that, we can do some of these other clever things. But the basis of this is that it's not very clever to have somebody on rapamycin every week and then have them have a big stroke. That's a serious miss. That's a serious problem, that's not been assessed. So coming into the practice, what do you need as far as imaging, and what does it cost? I think that you need a whole body MRI, including an MRA head and neck, and you need a neuroquant to understand, are there areas of your brain that are shrunk? Do you have white matter disease? Do you have an aneurysm? As part of the whole body MRI, you're getting a separate assessment for malignancy, which I'll talk a little bit more about. You need a CT coronary angiogram, and you need to get a low dose lung CT. And those are basically your imaging coming in. And it's something where the MRI for the detailed one costs about $1,600. The CT coronary angiogram costs $500 to $600. And then if you get plaque analysis, then that adds another $1,000. And the CT of the chest ends up most places being about $160. So that's what all that adds up to. And then there's lab work, including some labs that your primary care doctor won't have ever gotten on you, that all of them have evidence to being things that should be optimized. But one of the rules as a primary care doctor is never order a blood test that you don't know how to interpret or treat. So, it's like it's like if you order homocysteine, well, if it's abnormal, what are you going to do? And what do you actually know about whether it's a problem having a homocysteine in fifth? And what does that mean to the patient? And if you don't know what to do with it, you would not order it, and it's not on any of the guidelines to order it. So why would you order it? That just creates a headache for you. Why bother, taking a look at what somebody's vitamin D is, or looking at their omega-3 index? It's like, well, then you would have to know what to do with that. And it ends up being something beyond the scope of what primary care is going to do. So, yes.
And there's the issue of time too, right? I think when you're seeing people with pressing acute issues and you're overburdened with patients, you don't have time to dig into all of this in a primary care setting. So it makes sense why people have to come see you, but I think a lot of people maybe don't realize the drivers of that. So I think you've set it up really nicely.
And one of the things that's actually a big negative thing on the medical workforce, is that the shortage of doctors is increasing, and they're getting filled in by nurse practitioners. The doctors who are there, they're burned out enough that you really don't get the benefit of seeing a doctor. It's like they're supposed to have all this additional training, and yet they're just churning the wheel. It's like you go in there and you're on lisinopril for your blood pressure. Is that actually the best medication for you? That is never even going to be considered. It's going to be a refill. It's not going to be, hey, is this the best thing for you? It's like you don't have the time to deal with this. So one of the problems with the medical workforce is that standard primary care doctor has probably 1,500, 2,000 people on their panel. I'm realizing that for me to practice like this, that I can only treat about 70 people. So there's just the practical aspects of this, is that there are even if this became normal medical care, who's going to actually implement it? It takes too much time. So it is something where it is a niche for people who go, hey, this is something where I really do want to make sure everything's optimized, but there's going to be a cost to it, because your insurance is not going to consider, CT angiogram medically necessary. Doesn't cost that much, especially given, what is, number of patients who go, hey, I'll go ahead and take a trip for $3,000 or $4,000. Like, that covers all your imaging, but you skip the trip. But what's it worth to you for additional year and additional 10 years and additional 20 years of quality life where you can take more of those trips. So I think that there's a value proposition with this, but it is something where, yeah, there's some resources. And once we find something abnormal, like when I get a chest CT on somebody and there's some abnormal nodules, then next year your insurance will cover the follow-up scan, or we see something abnormal on the CT coronary angiogram, then things get covered. But they won't pay to cover it yet when you end up in ICU and they spend $100,000 as a result of something which could have been discovered, that they pay for. But it's only once you have overt disease. It's not when you have this disease where you're going, hey, I want to make sure that I don't end up with these bad outcomes where I could end up dead or disabled. It's a little bit of a disconnect. So I'll go through kind of the vascular and cardiometabolic stuff. Yeah, big thing is blood pressure. We're not even measuring it correctly. I usually use a device called a Connect Pulse. It's CONNEQT that looks at central blood pressure. It's very interesting what blood pressure your forearm is getting, but I don't see too many of my patients concerned that they're going to have some type of stroke or attack in their forearm, yet we're measuring the blood pressure there rather than actually measuring central blood pressure. So we measure it correctly and make our decisions based on that. But then you get a whole bunch of other data with that. You get arterial stiffness is a big thing, how much blood supply your heart itself is getting in between heartbeats. Those are additional data points that you get from having one of these devices, which costs a little over $200. But it's something where you'll be able to use this device for 10 years for that to have a better measure. Where's your insulin sensitivity? Something which most patients have never had measured, but is a big factor on how your brain health and your vascular health is going to do. It's cheap. Your doctor will measure a fasting glucose. All they have to do is add a insulin level, which costs $10, and you can figure out insulin sensitivity, where your lipids are. So as far as actually measuring lipoprotein A, measuring ApoB, and taking a look at different targets based upon whether you have disease or not. Whether you have an ApoE4 changes that a little bit as far as what our goals are. So taking a look at that and saying we want to put you at a number where you're very unlikely to form any disease, but we also need to know if you have disease. Other genetic factors, there's a genetic test called CardiaX, which looks at about 30 different genes that either decrease or increase your risk of vascular disease. And for example, one of the worst ones is 9p21, which a lot of times these people are having heart attacks before age 50 without being a smoker and without having horrible lipids. Totally discoverable, but you have to test for it.
So Grant, with the genetic
Yep.
tests, so you have these panels designed to assess a certain risk or pathway or organ system. Eventually, the cost of those panels probably adds up quite a bit. At what point do you recommend a patient just gets their genome or their exome?
Yeah, I think that there's the genes and then there is the manifestation of those genes. And to a large extent, just getting a CT coronary angiogram and getting an MRA head and neck tells you, despite everything that you've done in your life, did you form disease or didn't you? So in that situation, I don't think the genes make a big difference. A lot of times more curiosity when you have somebody who you go, they had a pretty good lifestyle and they've got all this disease. Why did this happen? And if people want to dig in, then doing a whole genome, or doing one of these focus tests as far as, why did this happen? Is there something which is going to be genetic that you're going to pass to your kids? Those types of things.
Got
But as
it.
far as I think the bigger issue is everything that's present in your system for however many years you've lived, we can take a look and say objectively, did you form disease? And if you did, then the treatment's going to be very similar irrespective of what your genetics are. We're going to optimize all these things in order to, and then we'll monitor and make sure that you're not forming new disease because sometimes we'll get even more aggressive. But yeah, it is something where I agree. It's a valid point as far as how much of this other testing, as far as causation, is valuable. And a lot of times, I think it's more curiosity when you see things that are unexpected. But I would say,
Makes
yeah.
sense. Yeah.
So we take a look at omega-3 index and make sure that that is optimal, and that's very rarely measured. It's inexpensive. It's something which relates to how much fatty acids you're having, primarily from fish. There are plant-based omega-3s, but it is something where a lot of those have issues with getting converted to DHA and EPA, which are important respectively for brain health and for vascular health.
Do you use the test, just the basic test that gives you the total levels, or do you worry about the EPA to DHA ratio?
So I think that is something where we've kind of moved to one that gives more detailed answers as far as at least getting DHA and EPA so that we make sure, because some people do things that are very heavy on one or the other. And I think that you're going to want a little bit of balance there. As much as EPA does get converted a little bit in the brain to DHA, you do want to make sure that you've got enough DHA. I mean, your brain is about a third by weight DHA, and you do want to make sure that you're cycling some fresh DHA
Yeah.
through your system. So we prefer people do fish, and it does become complicated with patients who are vegans.
Well, a lot of people take very high EPA supplements too, right? For
Yeah, we've
for different neurocognitive issues
Yeah,
or
and I think with that, it's much better to take it from fish for a number of reasons. Not so much for the fish themselves, but for your health. But it is something where a lot of the capsules do end up being rancid, depending upon which survey you look at. There's a risk, and that would actually worsen your health to take them if they're oxidized. For certain individuals, there are issues where you won't move those fatty acids because they're in a different format across your brain. So they'll do fine as far as your bloodstream goes, but for your neurocognitive action, you may not get very much of that DHA, if any, into your brain, particularly if you have two copies of ApoE4 or if you have some breakdown of your blood-brain barrier. So it's something where we know the fish source for these end up working, but we know that capsules, all their challenges, that you may not be actually getting much into your brain. And the other thing is that we know that with fish capsules, once you exceed about 1 gram of DHA and EPA, that you end up increasing progressively your risk of going into atrial fibrillation, which then increases your rate of stroke. Where we know that with consuming the same with fish ends up not doing that. So usually what I do is if people are taking fish capsules, I'll max them out at 1 gram. And then a lot of times people end up requiring a couple of grams a day in order to get good levels. So then the rest of it needs to come from. And our favorite one is black cod, which has a massive amount of
Hmm.
omega-3s. It's available at Costco. It's available at Northwest Wild Foods.
That's new to me.
Yeah,
Cool.
small.
More than salmon even, it
Twice
sounds
as much,
like.
yeah,
Wow.
and it's a nice mix of DHA and EPA, so you're getting plenty for your brain, you're getting plenty for your, vascular health, and it takes about 12 ounces a week of that, to get 100% of your requirement if you're not having any capsules at all.
And is it good?
Yeah, it is. I mean, we kinda cube it and make it and, grill it a little bit and make it into ceviche with some grilled onions and peppers
Ooh.
and a little bit of salsa and some lime and all that stuff, and it's actually good. It's not very fishy because a lot of people that aren't a big fan of salmon because oftentimes it is quite fishy, it's actually a really good choice, but it's very fatty.
Cool. I'm gonna check it out this
Yeah,
weekend.
absolutely. Other things, vitamin D, measuring that, there's so much, conflicting data around that. But one recent study that was interesting is of people who have had a heart attack, if you optimize their vitamin D, their chance over the next several years of having a second heart attack is reduced by 50%. So it's pretty clear that it's a good thing to do, but you have to actually measure the levels because the average person requires about 5,000 international units per day in order to get a good level in the range of kind of 40 to 70. And the US RDA is only 800 units. So when you just take a standard supplement or a multivitamin, you think that you're getting enough, but you have to measure your blood level. But unless you're out, farming the fields all day and getting plenty of sun, it's probably not going to be near enough. So you measure these things. I mentioned homocysteine before. That's something that we measure and optimize. The other interesting thing with homocysteine is a lot of people that have an abnormal level have an MTHFR gene that's abnormal, and that has to do with how you methylate your DNA, which also has to do with aging. So somebody who comes in with an abnormal homocysteine, it's not only an increased risk for vascular disease and for neurocognitive decline, it's something where they're probably aging faster, and it's something where optimizing that is something which is very reasonable as part of cardiometabolic health.
I wonder too, with your health focused customer clientele, a lot of them are probably consuming high protein, right? So do you is this something that comes up frequently that people kind of silently had high homocysteine levels?
Yep. I definitely have some that are unexpected, but it is almost always that they have an MTHFR gene, which is pretty common.
Oh, int
But it is something where the overconsumption of protein is a problem, and I think that I very much align with what Walter Longo, who has Prolon, has a lot of publications, a lot of discussions around how much protein you should have and how that should change with age. I think that his science is correct that you kind of get to, there's very little benefit for, people in our age. I know you're younger than me. I'll lump myself in with you though. So,
go for it.
but it is something we're going beyond about 1.2 gram per kilo per day. You're just generating extra IGF-1. You're going to be generating, excess malignancies. You're not going to be gaining any additional muscle out of it. As people get older, I think that, moving towards 1.6 and potentially having more of that protein from animal product makes sense. And I think there's data supporting that. So is something where those goals change, but we'll see a lot of younger people coming in, north of, 2 gram per kilo per day. And it's probably not a good thing for how you're going to age and what your malignancy risk is. So diet is a big factor, and it's not such a simple thing. And of course, everybody is an expert in diet because everybody eats and everybody has their strong views on what to do. And there's multiple different dietary patterns that are reasonable, but I think that, in general, it's, eat eat more plants, have more variety, have more fiber, 30 different plants, nuts, seeds, so forth per week, 30 grams of fiber per day. If you're going to have animal products, make sure that you're having high quality, mostly fish. 3 eggs per week seems to be a sensible thing as far as neurocognitive decline. And making sure that you do measure your vitamin B12 and make sure that is optimal for your brain, and that also relates to people on an animal diet because the animals are now tending to be farmed in a different way where they're not getting the B12 from the soil. So there's a whole bunch of things where you should measure, and all this ties into to optimizing things. I'll move on to the next couple of things that we look at. We do look at a uric acid, which is a minor risk factor, but if it's high, is a problem. And then we look at vascular inflammation with a high sensitivity CRP. And then also we look as far as the metabolic stuff. Does somebody have fatty liver disease? What is their body weight and composition? Where you don't do something as simple as a body mass index, you get a whole body DEXA, take a look and say, do you have visceral fat? How much do you have? What is your body makeup? Because some people you can have a BMI of 22 and have significant fatty liver, and you can have a BMI of, 35 and have, massive amounts of muscle and have no visceral fat. So the BMI is not the way to go with this. You want to know, does somebody have visceral fat? So you go and get a whole body DEXA for that. And, those end up being self-ordered. They tend to be $100, in some places in the country, or $50, like in Seattle and Los Angeles. A couple of rare times things are cheaper there with body spec.
And you find that's all you need to assess liver fat? Because there are other more expensive imaging modalities for that too, right?
Yeah. So I think in general we're happy if somebody's liver enzymes are fine and they don't have excess visceral fat, as far as saying we're fine with that. There's also other measures that we have as far as, fibrosis index based on labs. In general, it's going to be a superior thing to just look at where your visceral fat is. And that is cheap to get that. And also it's a trackable item, which I think is a good thing to have, is that you come back and you go, I'm 35% fat and I didn't think I had that much, and I've got, 4 pounds of visceral fat. We go away and do some things, and then you go and check it again in 6 months and go, "Hey, I've made some good progress." And, you see your insulin sensitivity coming down. You get some positive feedback on this as far as cardiometabolic disease. But yeah, with cardiometabolic disease, what we look at, this is going to cover stroke and heart attacks. So you need an MRI, MRA, head and neck in order to take a look. Do you have blockages in your carotid, your vertebrals through the circle of Willis? Do you have an aneurysm? Do you have white matter change, which is very common? And that's something where you're basically eating away your brain slowly with microvascular disease. And a lot of people who have the normal CT coronary angiogram who have, either blood pressure that's not optimal or lipids that aren't optimal have white matter disease. And this is something where it's interesting. The radiologists oftentimes will read these scans in a way that I disagree with. They will say, 62-year-old female, has white matter disease typical for age.
Yeah,
And it's
yeah.
something where, yes, they have white matter disease, but I have 80-year-olds who have no white matter change. So it's something where it's common for age in our society. But it's something where that is how your brain is going to get atrophy. So you basically having small little strokes all over. You don't come in dragging an arm or a leg or having trouble speaking.
Well, and what a missed opportunity. What a shame, right? If that were caught and
Yeah.
addressed the first time it came up, think what that's going to do for that
Yeah.
patient decades later.
Yeah.
Like,
No, you
so
you know,
frustrating.
you know, you know at that point that there's things that you really need to optimize, but also it's a motivator for patients when you say, "Oh,
Yeah.
look, you've got a little bit of white matter change. We'll monitor this over time, but we know what causes this. So let's optimize all these things and make sure we don't form any more because it's early disease right now. You've not actually got volume loss of your brain." But continue this for another 10 years, you're going to have volume loss. And that means that you're going to be thinking a little bit more slowly, having more latency when people speak with you, having more trouble finding what it is you want to say back because everything's getting diminished. So I think that those types of things, and yes, there's a cost, but it's not, it's not a ridiculous cost for what the payoff is.
Well, and I think it can really be a wake up call for
Oh
people
yeah.
too, right? Because we all know we should be doing a lot of things that maybe we're not doing. But when you see that objective evidence of the damage that's being caused in your brain, I would imagine that gets people to sit up and pay attention in a way that maybe they haven't been able to before. And I could see myself responding this way too. I think it's very powerful to have objective evidence of aging.
Well, especially when you've been told that everything's okay. It's like a lot of these people, are going to Cleveland Clinic and they're, getting told everything's great, and this is a problem. I'll show you very briefly. This is one of my patients. There's no patient information on this. On this study, but as far as as far as name or location, but this happens to be one of my patients that ended up having a scan and got significant blockages and completely unexpected. And I'll show you what that looks like here. So here's left anterior descending artery. Here's cross section of it. You see this narrows to almost nothing. So this
Yeah, wow.
calcified plaque, this is non-calcified plaque. You come down here and you see this artery's narrowing to very little there, and you're not even in the worst spot yet. You've got this area here looks pretty bad. This is somebody who had no reason to think that they had any disease at all. And yes, it's kind of it's a wake-up call when you kind of go, that this is something unexpected, but along with it, it's manageable because nothing bad has happened yet. But this is the nature of the problem is that you need to take a look at all of this and actually truly assess where you're at as a general principle. So I'll blow through the rest of the things fairly quickly because we're running tight on time. But I think conceptually we've kind of put it in the minds of people that there's a way to do this and actually detail where your risks are. And then once you know what your personal situation is, then you can mitigate all the bad things that might happen to you. So that, especially with cardiometabolic disease, that is something which is almost 100% manageable if you know. Problem is when you don't know. And because when we say, "Hey, you've got this scan," hopefully it gets caught much earlier than that particular image. But it is something where you go, this is something where I need to jump in and be much more aggressive, and then you'll monitor it and make sure that it's stabilized. So I think that is a real value just conceptually of how to approach your own healthcare before you start going after all the cyber longevity stuff. And usually there's plenty of substance on most people to work on in this space before you jump into something else. And also the benefits when you take a look and see all these speculative therapies, which I partake in some of those, and I would not talk badly of any of those, but it's something where this right here has very clear benefits to managing this. where the others are speculative. So take care of the stuff that has evidence first, then go to your clever stuff. Because I think actually the real clever stuff is this boring traditional stuff. But you die of stroke, you die of heart attack, you die of, multi-organ failure with your liver failing due to fatty liver or your kidneys failing due to diabetes. Those are all things which are essentially 100% preventable if you know about it and you have somebody who's aggressively going to manage it so that it doesn't cause disease.
And you've given us great examples, right, of people who they care about their aging trajectory and their health and longevity, and they're seeking care for this, and they come in and they see a surprise like that image you just showed us. I mean, someone listening to this probably has similar problems, and if you don't go get assessed, you're not going to know it's a problem. You're not going to address it, and you're going to have something terrible happen, like a stroke. It's really a shame that this is being ignored the way it is. But
Yeah.
you're doing good work to change that. So thank
Yeah.
you.
No, I think that people just being just familiar that, these tests are available and they're not that expensive. The whole body MRI is self-ordered. You do not even need a doctor involved. So you can go to Simon Med, you can go to Ezra, you can go to Pronovo. I prefer Simon Med because they do the NeuroQuant and it's the most cost-effective scan at $1,600. It covers everything that I want. But there's other centers around that do this, and it's some.
If you pull the trigger and you spend the money and you do it, how long until you need to do it
Yeah,
again?
it depends what you're wanting to mitigate against. And so if you have a normal CT coronary angiogram or have some minimal disease and your lipids are reasonably controlled, you're controlling your vascular risk, 7 or 8 years for CT coronary angiogram. For the whole body MRI, if you're looking at, where your brain is at, I like to get that every 3 years as far as the detailed brain scan. But then what we'll talk about in a minute makes the whole body MRI a basic MRI that's less expensive, a yearly endeavor and I'll explain the rationale for that. So so I think we kinda covered the cardiometabolic stuff, and yes, we kinda skipped over as far as diabetes, prediabetes, but we're gonna optimize all that, whether we need to use GLPs, whether or not, or whether, whatever we will get that under control and get people doing better on that. The next thing that kills and disables as people get older are going to be infections, which are interesting that as you get older, that becomes more of a risk. It's not so much of a risk when you're 50, but when you're 70 or 80, it is. And I think that the quick thing that I tell people is make sure that if you have signs of a serious bacterial infection, you get assessed early. I see so many people in the ER come in and they're quite sick and they've been sitting at home for 5 or 6 days with, fever and belly pain or whatever. And they're seriously ill where they've just been sitting there watching themselves dwindle away, and each day causing additional organ damage. So I think the big thing is be sensible, and when something's not going well, do go and get assessed urgently. Don't call your doctor and they'll say, "Well, I can see you 4 weeks from now in the office." I mean, it's not that type of problem. So I think making sure you do stay up with your immunizations, with multiple immunizations, having strong evidence for decreasing your rate of death and decreasing your rate of neurocognitive decline, with probably the strongest evidence being for shingles vaccine, but also influenza yearly, pneumovax, RSV, tetanus. All these things seem to be very sensible, and staying up on those do end up diminishing your rate of death and disability. The third.
I think too, Grant, we should mention for anyone who doesn't know, that they might be wondering why you're talking about ER medicine and longevity medicine, but you're one of the few physicians out there that does both, right? So so you're seeing people for this longevity evaluation consultation, and longevity focused care on an ongoing basis, but then you're also a practicing ER physician where you're seeing the consequences of not taking care of these things over the years, right? So I think that perhaps gives you a unique perspective, and it maybe is part of why you pay so much attention to these major causes of death and disability.
I
Maybe I'm wrong.
No, I see all the failures. I mean, this is the thing. I mean, I see, there's people that don't have good primary care who come in, and I mean, I see disasters. In their 20s who are, literally, are on death's door, because of, poor life choices and, smoking. And, I mean, I see so many people in their 20s that don't even have a single tooth left in their head. Everything's rotted away. They're obese, they're smoking, they're using injection drugs. you just see that spectrum, which, those individuals are going to take quite a bit of motivation to be coming and seeing me in this type of practice. But there's this whole other larger group of people that are getting basic primary care who I'm seeing have, regular failures, which were avoidable. Um, so in that's kind of part of me putting things together in this order is I kind of take a look and go, well, where is it that I'm seeing people come in, have unexpected things, and what could have been done to make sure that that actually was managed before it got to a crisis? Because at the point you're seeing me in the ER and I'm diagnosing something bad, it's been a missed opportunity for somebody. Yeah. So the infections are a big deal. For a lot of people in kind of middle age, because we can manage your heart stuff, we can manage your stroke stuff, we can manage your metabolic stuff. Malignancy is a tricky one, and this is something where 70% of malignancies do not have a screening test. So that's a little bit of a problem. You go, okay, well, I get my skin looked at and I don't have skin cancer. I do, and it got taken care of. I get a colonoscopy or I got the Cologuard or, whatever. So, my colon cancer screening is done. And none of those tests are perfect, by the way. If you're female, you're getting a mammogram on schedule. If you're male, you may be getting your PSA checked. So that takes care of about 30% of malignancies, but then there's the other 70%. And this is something where that's where I do advocate for a yearly whole body MRI, and the basic one, depending upon where you get it and how you get it, ends up being between 800 and $1,000 typically, basically as a screening for anything that's changed, preferably at the same imaging center so they have things to compare it to. But it is something where getting that done yearly is a very sensible thing to do. So, and you kinda go, why that interval, something special about, every time the Earth goes around the sun. I think that in general that you want to catch disease at stage 1 or 2. It's very easy to clear up at that point. You do not want to discover disease at stage 3 or 4. It does usually take a while. I think that having the backup, backup for breast cancer. I had a patient earlier this year who was kind of in between mammograms and I think had probably another 9 or 10 months before she was due for another one. We did an MRI and there was some little area that looked a bit like her breast on that. And that led to an investigation and, picked up stage 1 breast cancer earlier where it might have been, significantly later had we just gone through routine surveillance with the mammogram every 2 years, which is a recommendation.
So I'm curious what you think about the counter argument because we hear, the advice against getting full body scans is that you're very likely to find a false positive and cause a lot of anxiety and expensive follow up on something that was not a real finding, right? So I'm wondering in your practice when you're doing this, well, how often are you seeing each outcome? How often are you catching something important and real versus a false alarm?
Yeah, I think that it's actually the critical item is that you have somebody who's managing that result who understands how to mitigate those risks. So it is something where, yes, I've had patients need an additional imaging study to look at something. As far as having a procedure done to them that was not medically necessary, not, but it is something where, yes, it is a risk, and everybody has to understand that there are times where you're not going to be able to sort something out without a biopsy, and they can choose the pros and cons of it, but I think that having that knowledge, most of my patients would want to be given the decision as to, "Hey, you've got this abnormal growth on your kidney. There's pros and cons. We can go ahead and image it again. We can take a look at it on CT and see if it looks more benign. If it's not looking so benign, then, probably, advance with that. Is there the possibility that you're going to do that and end up, not finding disease and having somebody go through a procedure? Sure, that is a risk and it's a valid argument, but it is something where I'd rather have the person aware of the pros and cons of each. And for most things, it's just going to be a repeat MRI every year and just make sure things are staying stable and not changing for most things. So and yes, everybody's going to have some abnormalities, but I think that it's something where you have information. It's what you do with that information that becomes an issue. And I think the argument of saying you're better having no information because that information could harm you is something where, well, it depends on whose hands, but yeah, there is that risk. But patients need to be aware going into this that they're going to get some information, and then what do you do with it? Say, and I think the other area that's interesting that we've started doing is low dose lung CT for everybody. I've got 4 patients in my practice who have had lung cancer. All of them discovered at stage 1. The earliest, who I think was age 37. The oldest one was late 50s. Thing to be aware of is that lung cancer is one of the top killers of non-smokers, and this is unanticipated. But the reason why is that lung cancer happens about 20% as often in non-smokers. Smokers, the problem is it's extremely fatal, and it's usually discovered late, stage 3 or stage 4, where at that point you're going to die from it almost certainly currently. And but if it's discovered at stage 1, very easy to clear up. I mean, essentially 100% cure. So it's something we're getting that test done, and it's low radiation, less than 1 millisievert, and at most places it's $160 to self-pay for one of those. So I think that is a reasonable thing to do because the MRI will miss that. You kind of have to know the sensitivities of your tests for everything, and any test that you pick is going to have a risk of overdiagnosis and underdiagnosis. But I think that this is the best I've come up with so far as, how do we do this sensibly and reasonably cost effectively, because malignancy in middle age is a common cause of unexpected death or disability. And if you get a malignancy diagnosed late enough to where you're needing chemotherapy and so forth, that takes a bit off of all your organs, including your brain. And, it's something where, the older you are when that happens, the more it seems to take off your brain and your quality of life with, neuropathy, with cloudy thinking, all this stuff. There's oftentimes not gonna come back. So there's a quality of life, issue there to be dealt with.
Well, in animals, it's been used as a model of accelerated aging, right? Well, either chemo drugs or radiation. So it's definitely something that's nice to avoid if possible.
Absolutely. And then I think the next couple of domains we look at are fairly quick. We look at osteoporosis, we look at trauma, frailty, sarcopenia, making sure those things are avoided, or if they are present, that they're identified and managed. And that's something where we're getting a DEXA scan. A lot of times getting a DEXA scan earlier than when your insurance would recommend it, because the problem is that a lot of times people get their first DEXA scan, they're 70 years old, they already have, T-score -4. It's pretty hard to get it back. But if you had a known back when you were 55 that you had a T-score -2 and gotten on it to that point, you might not be in that situation at age 70. So early identification of problem, I mean, especially, thin Caucasian woman, are kind of our biggest risk factor, which I have a lot of those in the practice, tend to be fairly thin, and it is a risk. So, but we see it in men too. And we see it in all races, but it is something where your classic high risk is going to be a thin Caucasian woman. I see it in men, I see it in all races, and it's just a slightly different pretest probability as to what you're gonna find.
And on the sarcopenia side of that, obviously you get some lean mass information from a DEXA. But do you also do a functional measurement of strength at all, or how do you?
I need to, as far as, that is something where we need to be doing that yearly as far as, grip strength, and also, the tests where you're going to see how many times you can sit down, stand up, and
Yeah, yeah.
I think that those things are easily done at home and can be done remotely. And I think that a lot of my patients are kind of beyond that as far as their fitness, where it wouldn't make sense to do it, because a lot of them are, working out, an hour plus a day doing heavy weights and stuff, and be silly to do that. But for some of them, I think that that there's definitely a role for that. Patients in my practice tend to be fairly engaged, and exercise tends to be a pretty universal thing that they're doing substantially. But I think as far as in a general population, absolutely. Those things are of value, and, avoiding trauma is a huge thing. People don't recognize that, you're 17, you fall over, and you break a hip, a totally different set of consequences. And if you're 30 and you do the same thing, your likelihood of if death is about 30% of the year, if you have that happen, and it's not from the hip fractures, from all the things that spiral as a result of that, with the recovery and all the rest of the things that happen with that, that we see that death rate. So I think that, being very cognizant, not being, 70 and going up and cleaning your gutters, pay somebody else to do it, this type of thing, even though you're capable of doing it, probably a better idea in case something goes awry that you get somebody else to do it. So being sensible, not, I have a lot of individuals who, ride motorcycles and do mountain biking and all that stuff, and you kind of go, it's like, there's a risk benefit to all this stuff, and you want to have fun, but you don't want to end your fun. So you do have to be, thoughtful around what you do. Next area we look at is neurocognitive decline, which is complicated, but it's so many things with lifestyle. It all falls into kind of diet, exercise, sleep, stress management, your vascular disease, your metabolic disease, all these things fall into what happens with that. And there's some detailed focused items on that. There's ways to monitor that. There's ways to test for it. There's ways to specifically design activities for people that are having some weaknesses in certain areas to make their brain do some exercise in specific areas. Um, but it is something where it's very important, because if you end up losing your brain function, that is certainly a problem, and you do need to independently be looking at that and recognizing that all these things play together very tightly. But if
So I'm curious. I see on your list that you assess and treat hearing loss, which a lot of people might not know. That's one of the major, maybe the biggest risk factor for dementia,
yeah.
is having undetected, untreated hearing loss. Do you find often that people come in and maybe have some subclinical hearing loss that they were unaware of?
Yes. Yes, I think that that is something where doing screening and sending somebody for audiometry is a very, very sensible thing to do, and it is something where we do find a reasonable percentage of individuals, in their 50s, 60s, 70s that have significant hearing loss. And the good news is that with correcting that, you end up seeming to get rid of that additional dementia risk.
It's an easy one to fix, right?
It is an easy one to fix, it's an easy one to test for, and for most people, their insurance covers it, so you're not doing anything self-pay, although some of the hearing aids can be expensive and self-pay. But it is something where, there's things to test for and things to be treating, and yeah, it's kind of a long list. I mean, we take a look also, at gut health and, skin integrity, which makes a difference even to your inflammatory markers. There's things that need to be looked at as far as, do you have toxins in your body? This is an increased issue with plastics and environmentals and other things. Do you test for that? Are there chronic infections going on? Periodontal health is a massive one also. I mean, it's interesting. In one study, if you lose a tooth and you don't replace it, each tooth that you lose adds an additional 18% to your dementia risk.
Oh
So,
wow,
so but if you
that one's new to me.
if you
Yeah,
replace it, risk goes away, but it's
crazy.
expensive and, to replace a tooth. So that's, but having good dental health, if you have P. gingivalis in your mouth, you have an increased rate of both dementia and heart disease. So doing a oral microbiome is on the list of things. Looking at, nitric oxide optimization, helping your vascular health is kind of a separate area, and interestingly, cruciferous vegetables, things like erectile dysfunction medications like tadalafil can all play into that. Super beets or other beet supplements, or just eating them. Then we do look at things as far as, the clever things are more kind of mitochondrial optimization, autophagy agents, supplements, peptides, those type of things are kind of things that are held for the end once you've kind of, gone through and optimized all the rest. But I think that's kind of the platform of how I kinda organize this and think about it. But the cardiometabolic, we appropriately spent the longest time on that, because that overlaps everything else.
Definitely upstream of many others, right?
Absolutely.
Well, this is great. This is really, really helpful for me, and I think I'm really glad we're talking about it because I think this is often a domain of longevity that does not get the attention that it deserves, and where some of the biggest opportunities are. So I
It's just
really
back
love how you set that up for
it's
us.
just back to basics, and it's good primary care, but good primary care is not common, it requires this amount of detail. But this is what I consider to be good primary care, is managing all these things, but it takes too much time for what you can get in the
Yeah.
10 or 15
Well,
visits.
it's back to the basics, but using them in a much different, more comprehensive way, which I love. So, yeah, thank you.
And definitely feeds into the gray zone as far as this is where we want to discover things before you get overt disease, and this is the way that I propose that you do it on a macro level, not on a cellular level, but actually looking at things and going, where are we at, right? And just
Love it.
discovering things before you get into trouble.